This conference will now be recorded.
Hi, everyone, and welcome to the AnCan High-Risk, Recurrent, and Advanced Prostate Cancer video chat session for Tuesday, April 28, 2026. I'm Len Sierra, and I'll be moderating today with a little help from my fellow moderators, Rick and Dr. John, and all of you are very well-informed, well-educated attendees. As a reminder, this video chat is for informational purposes only. Nothing contained in this discussion should be construed as medical advice. And we want to acknowledge and thank our sponsors. They are Foundation Medicine, Novartis, Telix, and Blue Earth Diagnostics. And we will next go to our first of three newbies, Jan Nielsen. Welcome, Jan.
Thank you.
Where are you living, Jan?
In part of the year in Tennessee, part of the year in Pennsylvania.
Okay. And how did you hear about AnCan?
Don Rogers told me about AnCan.
Don Rogers, thank you, Don. How old are you, Jan?
74.
74. And what was your age when you were first diagnosed with prostate cancer?
68.
68. And do you recall your Gleason score at that time?
3 + 4.
3 + 4. And do you remember what your PSA level was at that time, at diagnosis?
Not exactly. I think it was in the middle single digits.
Middle single digits, okay. Did you have any scans done?
Not at that point. I did later on when the recurrence occurred.
All right. So what was your first primary treatment after you were diagnosed? Prostatectomy, okay. And let's go back to the pathology reports. You were 3 + 4. Was there any unusual pathology like cribriform or intraductal carcinoma?
No.
Nothing, okay. And the prostatectomy, when did you have that?
January of, let me think here, 2020.
January 2020. And anything other than the surgery at that time? No hormones, no radiation?
No radiation at that time.
What was your PSA subsequent to the surgery?
Below the lower limit of detection.
Okay, and so when did you first have a biochemical recurrence?
About 4 years later.
4 years, okay. So 2024. And at that time, did they do any scans?
Yes, we did a PSMA.
Okay, what was the result of that?
There was cancer around the prostate bed and 2 small spots nearby.
Okay, nearby as in pelvic lymph nodes?
No, they're in bone.
Bone, okay. Do you know the location of the bone mets? No, okay.
No.
So what was your next treatment?
I was on Orgovyx for about 8 months because I wanted to postpone radiation. I talked to a couple of different radiation specialists, and eventually, about 8 months later, we did 33 sessions of external beam radiation.
So you were put on Orgovyx for 8 months.
Right.
And only after then did you have the radiation? that a yes?
Yes.
Okay. So what did that bring your PSA down to?
Below the lower limit of detection.
Okay, very good. And so when did you have the radiation?
Let me think here. That would have been at the in fall of 2025.
Okay.
September, October.
Did they radiate just the prostate or the pelvic region?
Rated all the sections, the pelvic, the prostate bed, as well as 2 other spots.
2 other spots, as in the bone mets, or?
Yes.
Okay. So what has happened since then with your PSA?
The PSA has been below the lower limit of detection, most recently measured about 2 weeks ago.
Up until 2 weeks ago, you were still undetectable.
Correct.
Okay. So, did you have any genetic tests done?
No.
Okay. Any cancer in your family?
No.
Okay. Do you have any questions for the group?
Yeah, I wonder with that profile if anybody knows of literature or personal experience of what the future might hold for me.
Well, none of us have a crystal ball. We don't know what the future might hold for you. It's possible that you won't have any further biochemical recurrence, but you might. And unless anybody here wants to stick out their neck and make a prediction, I certainly won't. Unfortunately, this is not a cookie cutter disease where you do this and you get that result. Lots of unknowns. Cancer can go into a dormant state, be quiet for years, and then all of a sudden you might have a recurrence. We don't really know. But I'll let anybody else take a shot at that if they want to answer.
I have a couple of clarification questions, Len.
Go ahead, Rick.
So you say until about 2 weeks ago. What happened 2 weeks ago?
It was my normal annual exam where a lot of things were measured, including PSA, testosterone, etc. This PSA was still below the lower limit of detection.
Okay, so what were they measuring down to? 0.1 or 0.01? And what was the actual PSA?
Less than 0.014.
Okay, less than 0.014. So you have no concern about recurrence at this point in time? You're just really interested to know where does your disease go from here? Is that right? Yeah,
personal experience. I'm a scientist by training, so I'm interested in either personal experience, but even more importantly, if there is literature out there that anybody could point me to that talks about various scenarios depending on your background and probabilities of recurrence or anything else.
Yeah, I mean, there is stuff, and we can send it to you. But I think the bottom line is that what we tend to say here is that you got to live in the present. Because if you start wondering, well, what could be or what couldn't be, we don't know. I'll give you an example. Close buddy of mine, he may even come into the meeting tonight, I don't know, was treated with 3+4 and got brachycedes in 2010. He had no issues for years and years, and then his PSA started to move, but not very much. It's still below 1. And he just found out a few months ago that, a few weeks ago, that he's got a lesion on L3. So the problem is we can't say to you where your disease is going to go. Now, what we can say is you took a long time to recur. What was your PSA? This is another question I had. What was your PSA level when you had your radiation treatment? Where was it when they intervened?
It had gone from below lower limit of detection, less than 0.014, slowly up to 0.1 and then 0.2. When it got to 0.2, I started consulting the literature and experts, and it was thought that radiation would be first a PSMA, and then radiation would be appropriate.
Okay, so 0.2 was the threshold. So basically, since your prostatectomy, your PSA has never been higher than 0.2. Is that correct?
That's correct. And again, in looking at the literature, it suggested to me that doubling time was an important factor.
It
It
is.
went from less than 0.014 over the course of several months up to 0.2. The doubling time was calculated out to about 6 months.
Irrelevant, because we don't put weight on doubling time. We don't put a lot of weight on doubling time when it's under 1.0. So doubling from 1 to 2 is not the same as doubling from 0.1 to 0.2. In a second, I'm going to put a link in the chat window for you, which I think you'll find very helpful, from a webinar that we did. Well, it was sort of a small webinar. It wasn't open to everybody, but the recording has gotten over 1,000 views in the last 2 months. And it was from 2 doctors at the National Cancer Institute. And they have a program right now, and they really have people like you in mind who, if they are recurring very slowly. And they have a program for that. And they succinctly talk about doubling time. And, you know, one of the problems is that doubling time doesn't mean the same at all levels. So doubling time with very, very low, at very low levels is not equivalent to doubling time in single digits. They explain this, and they say they don't put a lot of weight on anything less than 1. I think we probably do put weight, certainly between 0.5 and 1, but you have to be really, really careful. And certainly we don't put any weight on doubling time at 0.01. So 0.01 to 0.02 is not, for us, shouldn't be considered a significant doubling.
But what would you, Rick, or anybody recommend in terms of how frequently I should have my PSA measured?
That's a good question. Well, I have my ideas, but I've been talking a lot, so I'll let somebody else answer that one.
Well, I have a question for you, Jen. When your PSA was starting to rise again, were you still on Orgovyx, or had you stopped?
No, I stopped the Orgovyx when the radiation started.
Okay, so when did the PSA start rising? I mean, after you stopped Orgovyx, you were still undetectable, right?
Well, after it rose before I started the Orgovyx. Then I was on Orgovyx because I had other things going on in my life, and I didn't want to have the radiation right away. I came off the Orgovyx when the radiation occurred, and then the radiation led to the PSA going down below the lower limit of detection.
I'm still trying to figure out, between the time you stopped Orgovyx when you were undetectable and the time you started radiation, how long a gap was that? I presume that's where the PSA was rising.
No, the PSA was rising before I started the Orgovyx.
So getting
So why
confused
did
here.
you
You
have
said
the
you,
radiation therapy if the PSA didn't
Yeah.
come up?
Say again?
Why did you have the radiation therapy if your PSA did not come up?
It came up about 4 years after the prostatectomy. And I decided that in consulting with people and thinking about deciding I needed radiation, but that was not a good time in my life for other factors. So the doctors and I decided that we would do Orgovyx for several months until it was a good time for me to do the radiation. And then
So
I had the
you just
radiation.
did the radiation at that time because of convenience, not because your PSA bounced up.
Correct.
You just got around to it. So basically, you've been non-detectable for quite a while. You have a nice lazy you have a nice lazy prostate. You don't really have.
Steve Lodge, mute, please.
I'm getting a lot of background noise. I'm not hearing people individually.
Yeah, I know.
I'm sorry.
Steve Lodge, somebody mute him.
Yeah. In fact, I'd say if everybody could please mute unless you want to talk. That would help us a lot. Thank you. Dr. John, you're accepted.
I think I'm understanding the trajectory of this, and I think I understand what Len was getting at. And it doesn't sound like there actually was a recurrence before the EBRT started. He was just finally getting around to it. I don't really know why the Orgovyx got discontinued when it did, but nevertheless, he's now undetectable and not on any treatment.
Right, but I don't think that's quite. I think what happened was there was, and Jan, you can correct me. His PSA started creeping up, and they decided to go on Orgovyx. Now, normally, if they're going to accompany the radiation with hormone therapy, which is a lot more debatable now than it's been in many years, and some doctors do. Most doctors do, some doctors don't. They'll do it neoadjuvant, meaning right before. We know that you can, in Jan's case, his PSA didn't start to creep up for about 4 years after he'd had the surgery. So they started him on the Orgovyx, but he didn't want to do the radiation right then. So they gave him 8 months of Orgovyx, which was more than he needed. And then when he was ready, he did the radiation. Mm-hmm. It's not that complicated. Look, Jan, I think what we want to do here, I'm going to put this playing the long game recording link for you in the chat window momentarily. Have you figured out where the chat window is, by the way?
Yes, I've been using it, chatting with people already.
Okay, great, good. So, I'm going to put this playing the long game in, and definitely watch it because I think it'll give you a lot of comfort. Feel free to come back anytime you want and to ask us questions. But I kind of feel like you're in a great situation right now. And it's not just this playing the long game. There are other trials going on. For example, the Andromeda trial, which Dr. Kishan is running at UCLA right now, is also for people who recur very slowly, like you did. And he has a radiation protocol for them, an interesting radiation protocol. But there is definitely a move afoot to minimize treatment. And so what I would take from this is that we should be looking in a situation like yours to minimal treatment going forward, probably even less than you might have had in the past. I know Jim Marshall wants to know if you are a veteran. I'm guessing not. Are you a vet?
No.
No. We have 3 new guys, so I'm just sort of conscious of time here. Does anybody else have anything they'd like to say to Jan before we move on to, I think David Frank is next on the list.
I just have a quick, one of his questions was how often to get a PSA. I think a lot of people would probably say 6 months would be fine for you. I like 3 months myself. After all, you're not on any treatment right now. So I don't know if Len and Rick agree with me, but I would say 3 months if you want to be a little careful, and 6 months if you're really laid back about it.
I agree with you, John. 3 months is what I would do. It's just information.
Yes, and I'd go with that. And here's the long game. By the way, any of these links that appear in the chat window, you can just click on them. They'll open in your browser, and you can watch them later or read them later. So here's and then come back next week or the week after and talk to us about what you think about this long game type of approach.
Thank you all very much. I appreciate your comments.
All right, Jen, thank you. Next, we'll go to David Frank, another new member. Can you wave your hand, David, so I can locate you? There you go.
I'm right next to you.
Well, not on my screen.
Okay.
Okay, so David, let's see. How did you hear about AnCan?
When I started my radiation treatment, I ran into a gentleman named something like Hurwitz or something like that with a CH, and he said there's this group, and he exchanged emails and got me in touch with you, I think.
Daryl, you saw Daryl. You're treated in New York?
I was treated in my radiation was in Westchester County, New York.
Yeah.
And high brachytherapy or high dose rate.
Okay, hold on. Let's get back to the beginning here.
Sure.
So how old are you?
Sorry, I'm 62.
62. And when were you first diagnosed?
That all began in July of 2025. Formal diagnosis August, September of 2025.
Okay, is that when you had a biopsy?
Yeah, I had a high PSA back in July.
And what was it? What was your PSA?
It was 186.
Okay.
Google is not your friend when you start looking at what that might mean.
Right.
And a friend of mine who's an attorney who also had prostate cancer said, go see this doctor at White Plains Hospital as quick as you can. He was a urologist, Dr. Lerner. He did an initial exam and scheduled MRI, biopsy, and the next step was a PET scan.
Let me ask you, David, what was your PSA before it was 186, and when was it?
Okay, this is what's really messed up, and I feel kind of embarrassed about it. When I was 50-something, I had a PSA done, and it was within range. My urologist said, you can come back for another one. I was seeing him for an acute condition. And I said, but I'm getting my PSA done at my primary care. He said, yeah, you can do that. And I thought I was, but I wasn't. So last July, I saw a different doctor in my regular doctor's office. You know, she was busy, he wasn't. And since I saw him for the first time, I said, "So you're shooting a PSA?" And he said, "Yeah, I can put in the order for that. I'll put down patient requested." And I thought, "Oof, wait a minute, this isn't part of the regular blood panel." I was mistaken. Anyway,
Okay. Okay.
it came back at 186.
Right. Okay.
And,
Did you have any symptoms at that time?
yeah, you know, and I was conflating them with other conditions that I had.
Okay.
A couple years before, I'd gotten rear-ended by a shuttle bus, and I was dealing with sciatica and you know, things that cause pain in the lower back and the groin. And I'd been through physical therapy and all that, and I'd gotten to a point where I thought, well, you know, I need more physical therapy or something. And, you know.
Okay. Okay. Let's see. So when you had your biopsy, what was your Gleason score, and was there any unusual pathology?
I had a couple of different Gleason scores. The highest one was a 9. That was on
4
the
plus
right
5?
side. 4 plus 5.
Okay.
That's all we need.
Yeah,
4
that's
plus
all we
5
need to
is
know.
enough.
Yeah.
Okay. And what about the pathology? No cribriform, no intraductal?
There was evidence of some intraductal and perineural invasion, and that
Right.
scared the hell out of me. And
That's not that uncommon, especially when your PSA is 186.
Yeah.
All right.
Yeah. And
So, all right. So you're Gleason 4 plus 5 intraductal, and so what was your first treatment and when?
And where?
And where?
And where? Yeah.
Well, the initial diagnostics were done at White Plains Hospital.
Right.
But in the meantime, this friend got me to talk to his cousin, who was a retired urologist, and he referred me to MSK in the city.
Okay.
And
Who did you see there?
I saw Dr. Karen Audio.
Okay.
And I saw also for radiology or radiological oncology, I am in the care of Dr. Daniel Gorovitz.
Okay. And is he the one that did your radiation?
He is the one who oversaw my brachytherapy. There was another doctor who was actually doing it at the time and somebody else who was supervising him, but Gorovitz was attest to having been present through the whole thing. Joshua.
So can I ask you, Dr. Karen Audio, what did she recommend you do? Just radiation, or did she recommend hormonal therapy?
No, she said she recommended hormone suppression.
Right. Which drugs?
First Orgovyx, followed up by abiraterone and prednisone, and she said you'll be taking them until September of 2027 because your Gleason score is high.
Right. Okay.
Like I knew what that meant. I'm like, okay, you know, if you say, that's what I'm going to do.
Yep.
Yeah.
Okay. So you had the brachytherapy, radiation, and any other radiation besides that? Was that combined? External beam. Okay.
Yeah.
And they did the prostate and the pelvic region?
Yeah. The I guess the MRI or the PET scan showed, they said I was still localized. I had spread through the right seminal vesicle and some evidence in the tiny lymph nodes.
All right. And the PSMA PET, what did that show?
The what?
PSMA PET scan? I think you said you had that.
Yeah, the PET scan showed massive tumors in my prostate. I think they took up a lot of the space within the prostate,
Right.
and it showed what they call localized spread.
Okay.
Which
T3B, Len. He's
The what?
T3B.
Okay. No bone metastases or distant
no
lymph
metastases.
nodes.
I was
Okay.
just flipped out. It was amazing.
Okay.
I don't know. I
All
really
right.
was
So
feeling the worst.
you're still on the hormonal therapy. What was your PSA subsequent to the radiation?
Currently, radiation finished in February.
Mhm.
I'm undetectable.
Good. Okay.
And the hormone therapy makes me feel weird.
Yep.
Things hurt sometimes, and I don't know why.
Mhm. Are you exercising, and have you changed your diet, or did you need to change it?
I talked to the they have nutritionists and everything, and basically they said that the only thing that you really should watch out for or be careful of are cured meats. Anything that has sodium nitrate in it or nitrite.
Right.
And they said everything else, there's not enough conclusive evidence to say that you should absolutely abstain
Okay.
from that.
And what about exercise? Are you doing
exercise? A bit of walking, and I have to tell you, when I was going through radiation, I really didn't feel like doing much other than coming home and sleeping.
So you had a lot of fatigue from the radiation. Any other side effects from radiation?
I didn't really notice it so much until afterwards, but pain and discomfort around the area that was irradiated. And coming off of radiation, there was about a week to 10 days where I had to urinate every 20 minutes almost, or it felt like that.
Has that improved?
Yes, it has. I still get some pain in the areas that were irradiated, but I don't know. To my untrained mind, I think that's tumor cells dying and receding from the areas that they had inhabited. I could be wrong.
So we recommend that in addition to cardiovascular exercise, when you get your blood pressure, you get your pulse up high.
Mm-hmm.
We also recommend weightlifting because you have muscle atrophy from the hormonal therapy. Are you doing that?
I try to do some weights, and I am walking. I have another issue where I just had an arterial blockage in my knee cleared. And it was a pretty big arterial blockage.
Okay. Maybe we should ask, do you have any other comorbidities besides the prostate cancer?
Oh, like diabetes?
Okay,
Type
you have
2?
diabetes?
Yes. I
You
have.
should not be, I don't know why they prescribed Abby. Isn't that kind of contraindicated for Abby guys?
They had concerns about it, and they prescribed it with prednisone, and my diabetes is pretty well controlled, but they said let's keep an eye on it and see how you're handling it, and I've adjusted to it. You know, with both Orgovyx and abiraterone, I had 2 weeks plus or minus of elevated blood sugar or inconsistent blood sugar and blood pressure, elevated blood pressure, just actually all over the place. And my body has seemed to adjust to Orgovyx and abiraterone together.
So has your blood pressure come back down to normal levels?
Yeah. I
Okay.
control that with lisinopril, and it usually keeps me locked at 120 over 80 or 120 over 70 something.
Okay.
And
How
I'm
often are
losing
you getting
weight.
your blood checked?
You mean like PSA and all
Well,
of
the
that?
whole, yeah, CBC, metabolic panel, PSA, testosterone.
I am, through MSK, I'm doing that about once every 3 months.
Okay.
I messaged Dr. Audio's office last week just because I was having pain, around my prostatic region and scrotum, and it kind of felt the way that I was feeling before I knew I had prostate cancer, but did. And they said, well, we can order a PSA. I said, sure. And it came back undetectable, less than 0.05.
So, David, I'm sort of keeping an eye on the clock here, and because we have one other new gent
Sure.
we need to work through. I think that that there are a few things we'd love to talk to you, if not this week, next week, more about how to improve your quality of life whilst you're on hormone therapy, because there's a huge amount of experience about that in here. One of the things, I mean, we don't necessarily agree with the nutritionists at MSKCC. Not that we're experts, but we've been around the block a few times, and we've heard a lot of nutritionists from a lot of hospitals. No question that cured meats are bad, but I think that most people would agree in here, even if they don't abide by it, that any red meat is bad. And that there are vegetables, some types of vegetables, particularly cruciferous, are better to eat. All these things are going to help. They're not going to cure you, but they're going to improve the likelihood that you'll get a long-term and durable remission from the treatment that you're on right now.
Yeah.
The other thing is, it's really key to exercise, even though, I mean, I went through the radiation, I went through a lot of hormone therapy. Yes, you feel tired. You got to get out, and you've got to do the exercise, rigorous walking, so you get your heart rate up, weights 2 or 3 times a week, even if they're light weights, because that's what maintains your muscle mass. That's those are some key things. Do you have any questions for us that you'd like to ask before we move on? By the way, we have at least one gent, he's not in the room today, who has been a Karen Audio patient for 7 or 8 years or more.
Yeah. No, I'm grateful for the care that I'm receiving, and I really appreciate your time this evening, and I look forward to hearing more about lifestyle changes and support. And it's nice.
Okay, now we forgot to ask you about genetic testing, David. Did you have any genetic
Yes,
sequencing?
did it, and I'm BRCA2.
Ah, you should have. You didn't tell us that at the beginning.
No, we
Aha.
didn't. We didn't ask. That's our job.
We didn't ask, but it's so important. BRCA2 germline. You
BRCA,
inherited it.
yeah, I
inherited.
believe I did.
All right. So here's what we'll do. Are you signed up? I didn't. I seem to. I remember when Daryl wrote to me about you, but he said to expect you, but we never saw you. So I think I have your email. But put your email, for good order's sake, in the chat box, in the chat window. You can send it to everybody. You can send it to just me. We have a separate group for people with inherited mutations, like Carol and yourself. Okay. And we'll sign you up for, we have both a mailing list where we send things around, and we also have a meeting once a quarter. So we'll sign you up for all of that. We have a lot of great support since you're living with an inherited mutation. Len, you have a couple of questions, 3 questions.
Yeah, Jim Marshall, let's get you going there. We know what you're going to say, but go ahead.
Yes, sir. Are you a veteran?
No.
Okay.
Sorry.
Pretty much.
All right.
I'm always
And-
trolling.
Yep. Pierre in New York, go ahead.
Has he had a DEXA scan?
Have you had a DEXA scan for bone density?
Yes, I did.
Okay. Was it normal?
It showed osteopenia in my left hip joint.
Okay. Did Audio talk to you about maybe Prolia?
No. They
Ask her about that. Okay.
Yeah.
Prolia.
Prolia, yeah, it's for osteopenia or osteoporosis.
Yep.
You
I was osteoporotic marginally, and I was put on a pretty heavy drugs for 3 years because the Orgovyx can make that worse. So definitely good point of Len, from Len, raise it with Dr. Audio.
How do you spell Prolia?
Prolia.
IA.
Well, just ask her whether, don't necessarily suggest Prolia. Ask her, should you be on a bone strengthener, is the question.
Or at least calcium and vitamin D.
Yeah, definitely.
She suggested calcium and vitamin D. Yeah.
Okay.
Steve Rue, go ahead.
Yeah, go ahead, Steve.
The words were kind of taken out of my mouth here. Whoever was asking that, the DEXA and the bone density, I'm paying the price for that now, not monitoring my bone density. I should have been checked every 6 months while on Orgovyx, and I would recommend that you ask about that bone density scan. Try to get that done at least every 6 months. See if which direction your bone density is moving. And there are bone strengthening medications. The second thing I wanted to mention is that I had a hard time getting motivated for exercise to help improve my bone density and muscle mass. Look around where you live, see if you have a YMCA that offers a Live Strong program for cancer patients and cancer survivors. It's a 12-week course, twice a week, and it's free. And that'll put you in a small class with other people like yourself, like ourselves here sitting now, and could give you the motivation to show up and work on that muscle mass, but also the bone. bone strengthening. That's a real that was a real problem I had because I did not check it every 6 months during my Orgovyx 2 years of ADT therapy. So I just wanted to mention that. Yeah.
All right, thank you, Steve.
Thank you so much.
Russell, Dr. Russell, go ahead.
Yes, Len, I like you. I sort of recoiled when David said that he was on ebetarone with prednisone with diabetes is not contraindicated because I don't think it's a good idea. I have a friend here, he's a urologist, and he's diabetic, and that's what he's recommended. And I just don't think that's a good idea either. But I don't think it's contraindicated.
Yeah, maybe that was too strong a word, but I believe that when patients have diabetes, they tend to go, instead of Abby, they tend to go to one of the lutamides, the receptor blockers. But Audio knows what she's doing, so they're monitoring everything.
Yeah, if I hadn't adjusted to it, or what do you say? If I hadn't, if it wasn't working, they would have taken me off it, I think.
Yep. Okay.
Well, it could be argued that you haven't adjusted to it necessarily. You got thin bones and slow thinking, and you're tired, and it's hard to exercise. So it's not like you've perfectly adjusted to those drugs.
I don't think. Do you ever really perfectly adjust to any of this stuff?
You got to do the best you can.
That's where I'm at.
Right.
You might not be.
Right.
All right, David, we're going to move on.
David, before we move on, just one last thing. Have you advised your relatives about the BRCA and have they been tested?
I've advised, I've sent letters. My parents, who were both 89, they are open to getting tested. They have not been contacted by the group that was supposedly suggesting and maybe offering the testing.
No, I think they have to be proactive. I mean, we can send you. I suspect Shasharet will take care of you. Take care of the testing if you need to be, but they have to be proactive. They need to call Shasharet and say, but what about, do you have kids? Do you have brothers? Do you have sisters?
I have a son who is 20 years old and he's too young to be tested.
Not true. Not true.
According to the study. Okay.
This is why we need to get you in to the inherited mutations group. We've got people who have kids of that age. They'll talk to you. He doesn't have to be tested, but he's not too young to be tested.
Fair.
Okay. And we'd be happy to connect you if you're interested, and let me know. I'll put my email address in there, but we'd be happy to connect you and talk to you. Brothers and sisters?
Yeah, I have an older brother with special needs. He's 18 months older than me. He and my parents know that they can be tested.
Yeah, well, he certainly should be, because he has a fair lifeline, and it's so important.
Yeah.
It's so important, you know. So anyway, we'll support you on that, and there are people even in this group here who are BRCA positive, and we can help you if you would like the help.
Well, yeah, I appreciate that very much, and I feel like I'm taking far too much time from this group right now, and you know, if you want to move on, that's fine. I have your email, Rick, and I will
We meet every week, David, so you can always come back. Next meeting is Monday, this coming Monday.
This coming Monday. Okay.
8 o'clock instead of 6 o'clock. Start time is 8 o'clock Eastern.
Yeah, and
Where do you live, by the way? I didn't ask exactly where you live.
Westchester County, New York. I'm about 10 minutes from MSK's Westchester campus.
Okay. Not too far from there. I'm at Mount Kisco.
Yeah, I'm Harrison Purchase.
Harrison
Right.
Purchase. Okay.
All right. We will now go to Mark Greenberg. Mark, how are you?
Okay, how you doing?
Good. How did you hear about AnCan?
I am a part of a support group that that's operated by Johns Hopkins, and I just heard about it last week, so I jumped on it. I did not know until a minute ago that you were a weekly group. I thought this was like monthly or quarterly. So if there is any kind of link I can go to find out the schedule for meetings, that would be appreciated.
Okay, so
AnCan.org, or you take over, Rick.
yeah, no, I'll put it in. You'll find our schedule at AnCan.org. I'm putting it in the in the chat. Our schedule for this group, which is the advanced group, I assume, are you recurrent or advanced?
Yes, I'm very advanced.
Okay, so the advanced group meets first and third Mondays at 8 o'clock Eastern. First and third Mondays at 8 o'clock Eastern. And second and fourth Tuesdays at 6 o'clock Eastern, always in this room. We also have a bunch of other groups, supportive groups. We have a bunch of groups for veterans. We have some great mental health groups. We have a men-only meeting, which is really, really popular, that meets twice a month. You can find all of that on our webinar. All of our meetings are free and drop-in. We welcome you, and we welcome anybody else from JH.
I appreciate it.
Whether they're in Baltimore or they're at Sibley or wherever they are, we have a bunch of Sibley people who are in here. We have a bunch of Channing Pala patients, and
okay. Well, thank you.
All right. Well, let's get started on all of that. So, how old are you, Mark?
I'm 73.
All right. And where are you living?
In suburb of Maryland.
Suburb of Maryland. What's the town?
It's Carroll County.
Okay. And when were you first diagnosed?
October 2024.
2024. Is that
Yeah.
right?
Yeah.
Okay. And 2024. How were you diagnosed? What was your PSA?
Well, it was not a PSA issue. I had a challenging time urinating. They diagnosed it as prostatitis. I was treated with antibiotics for 3 months. They just kept saying it was a resistant prostatitis. And then finally, they gave up on the antibiotics and they did a biopsy. And that's when they found out that it was probable cancer. And then I went for PSMA and then an MRI.
All right. So at some point, they must have done a PSA test.
Yeah, my PSA was 7.9.
Okay. And so what were the results of your scans?
That
Gleason.
Oh, yeah. We didn't get your Gleason score.
9, 4 plus 5, 9.
Okay.
The PSMA showed contained prostate cancer. I had a radical prostatectomy in January of 25. They said there was no lymph nodes, there was no trouble with the bed. Everything was clean. I was in good shape, and I was supposed to get my first post-operative PSA in May, and they expected it to be undetectable, and it turned out to be 167.
Wow. So it was 7.9 before the surgery, and then after the surgery, it was 167.
That's correct.
That is a disappointment, to be sure. Was there anything unusual in your pathology report?
Introductal.
Introductal, okay. All right, so May of 2026?
May of 2025, I got the PSA of 167.
Okay.
By June, I was on both Nubeqa and Orgovyx.
Okay. And are you still on those two drugs?
Yes, I'm still on those two drugs.
And have you had any other treatment?
No other treatment. No, I've been referred for radiological consult. I have the reason it was 167. They sent me in for another PSA, and it had metastasized to the pelvic area. So I have 5 tumors in my pelvic region.
So,
okay. And all right, so you started the hormonal therapy in June. And when was your next PSA after that?
It's been every 3 months.
Okay, and what so
my latest PSA was just 2 weeks ago, and it was 0.9.
0.9. Is that the nadir, the lowest it's ever been?
Yes.
Okay. And have you had any additional scans, like PSMA PET scans, after they discovered you were 167?
I have them every 6 months. I'm due again in June.
In June of this year. So you had one in January or December?
December.
And that's where they showed the lymph nodes.
Let me just butt in here because this is too weird. You had a PSMA scan before you had the surgery, correct?
Right.
And where was that done? Was that done at Hopkins?
No, it was done at a Charter Radiology.
And has Hopkins ever looked at that?
It's not Hopkins. I'm getting treated at University of Maryland. Of course, they looked at it. They ordered it. They looked at the PSMA and they looked at the MRI that they ordered. And both the PSMA and the MRI showed that the cancer was neatly contained within the prostate. And when they did the prostatectomy, their post-operative analysis was they got it all. I'm clean as a whistle, and my next PSA should be undetectable.
Right. But here's the thing. prostate cancer doesn't grow that quickly. So what was the time between that PSMA and the next one that showed you had extensive mets in your pelvis?
My surgery was in January of 25. My first PSA after that was in May of 25. And then they immediately sent me for a PSMA, and that's when it showed that I had 5 tumors. It had metastasized to 5 tumors in the pelvic area.
So between 125 when you had that first PSMA and 525 when they redid it, that's when this arose. Is that
technically the first PSMA you're talking about was prior to the surgery, so that was in December of.
Okay, so call me Pisha.
Right.
Yeah, 1225 to to 525. Dr. Paul, ever seen that one before?
No, and in view of the fact that the offending organ had been removed, it is most unusual. With regard to the lymph, you had lymph nodes removed just as
No lymph nodes there was no contamination in the prostate bed or the lymph nodes.
they were removed.
No, nothing was removed.
What? No, I mean, the pathologist had lymph nodes to look at
Oh, yes,
after the
yes,
surgery.
yes.
And they looked at those.
Clear,
and
all
clear.
All clear.
And they went back and looked at them again.
No, I don't know about that, but they were all very optimistic. I had my post-operative
Yes.
meeting,
But
and
their
everybody-
jaws must have dropped when you came back with a 160.
well, their jaws dropped and my heart dropped. Yes.
Yeah. And did you have any PSA immediately post-op, i.e. 3 to 6 weeks after your surgery?
No. They advised not to do that. They said that it would be contaminated by the surgery and not to have a PSA. They're the ones who scheduled the next PSA, and that was in May.
Okay.
And who's your doc at UMC? Who's your urologist at UMC?
Well, my urologist is not at University of Maryland, but my oncologist is at University of Maryland. It's Hussein, Dr. Hussein.
Okay, yeah, well, I know of him, but we also have a Siddiqui, who's a really good friend of ours.
Siddiqui is the one who operated on me.
Siddiqui operated on you?
Yes.
At UMC?
At University of Maryland, yes.
Okay. Okay, well, we know him well. He's a good guy.
He personally did the surgery.
Okay. You got us on this one.
Yeah, he's the one I met with post-operatively, and
Yes.
he's the one who told me looks great. Every reason to be hopeful.
Okay. Well, I think you can still be hopeful. You're not that advanced, which is the good news. We've got people who are a lot more advanced than you, I think. You've had PSMA. When was the last PSMA that you did?
December.
In November? December.
And I have one coming up in June.
Okay. And that did it show a shrinkage of the Mets?
A slight shrinkage.
Okay. And what exactly were the metastases? How many metastases were there when
Five.
5?
Right.
Yeah. And did you have any radiation treatment of those metastases?
No, they said that the tumors were too big, and to radiate them would be too much damage to the bone marrow.
Did you get a second opinion?
No, they took it to the tumor board for the hospital.
Yeah,
and,
I mean, here's what I would do. I would take those, since they're still of a sizable nature, I'd run down to Channing Paller and I'd get a second opinion on what she thinks at Sibley. And because that's, I've never heard them say, I haven't heard them say the tumors are too big. But I can understand how they're concerned about damage to the bone marrow. But to say that those tumors are too big, this whole thing sounds so weird. But that said, I would want to get a second opinion on whether you're a candidate for radiation, either from Channing Paller, and I think I'd start with her, or the radiation oncologist down at Sibley, whose name it's just escaping me, Carl something or the other, is the good guy there. But I definitely be doing that, because frankly, you're really borderline. If they're that big, you're borderline not getting chemotherapy if there's 5 and they're really large.
Yeah, that's under consideration. They're hoping that the next PSA is going to show additional shrinkage.
Well, you know, I'm not sure how long I'd be wanting to wait around if it were me, and I would be definitely looking for a second opinion. And you know, start with Dr. Palla. She knows us really well, and ask her if she thinks you should also be talking to a radiation oncologist. And I'm just concerned about this whole treatment.
Not just a quick, if something like this was presented to me, I would honestly wonder about the pathology specimen that was examined and the history you're pursuing. So I would ask, was your DNA ever matched to the pathology specimen? Because there's so much discordance that, and this happens. I mean, it's rare, but it happens that sometimes specimens get mislabeled, mistaken, they're read correctly, but they're just put on the wrong report. I mean, it's a shot in the dark, but I would like that to be clarified.
Yeah, I think it's a good point, but it's really moot in terms of my treatment. I mean, they may have made a mistake and they may have.
No, it's not. It's not moot in terms of your treatment, because there's a lot of other treatment options you could be going through right now, and you're not. You could be going through radiation, you could be going through chemotherapy, and these have been ruled, these have not been chosen, and this is why we would like to see you get second opinions. Kirtland DeVille is who I was trying to think of. So so I would definitely, I would make appointments with Dr. Palla and Dr. DeVille and see what they say. Have you been genetically tested?
Yes.
And any
No.
germline or somatic?
No.
Okay. So, I mean, sadly, Mark, we've just got to get going here because we've got a lot of people who want time. But if you take anything away from this, it's to get on the phone tomorrow, make an appointment with Dr. Palla, tell her you're an AnCan person, or tell the clerk you're an AnCan person, and we're recommending a second opinion as soon as possible. If they put you off for a long time, let us know. We'll have one of Dr. Palla's patients reach out to her directly and grease the skids, and do the same thing with Dr. DeVille. And I'm going to put Channing Palla, I'm going to put links to their profiles in the chat window for you right now.
Thank you. I look forward to at some point talking to some guys who have been on the same medications I've been on, because the reason I jumped on this group is just concern about side effects and how my side effects compare to other people's side effects, because they're recommending that I stay on these medications longer, and the side effects are obviously cumulative.
Come back next week, Mark, and ask that question. We've really got to get moving here.
Okay, thank you.
All right, because that'll be another 15-minute discussion.
Yeah, we've got a lot of people who have been on your who have been on your meds. So yes.
Thank you.
All right, thank you. Let's go to Tony, Syracuse.
Yes, just an update here. I've been on Orgovyx for about 60 days now. Had another round of blood work 4 days ago. My PSA took another drop. It is down to 0.064. And all the other factors, including the lipid panel and liver and glucose and all that, everything else is in normal range. And I'm still I'm tolerating the Orgovyx pretty well, just getting a few minor hot flashes. I had an appointment with Dr. Guercio at Wilmot on April 20th. The conclusion from that was that he had nothing to add or change to the plan that my oncologist here in Syracuse is following, Dr. Duffy. And so the recommendation, the plan going forward is to continue with Dr. Duffy and to follow up with Dr. Guercio's team about every 3 months. And so I've got another appointment with Dr. Guercio on July 20th. He has also referred me to a radiation oncologist for another opinion on the radiation plan and timing, Dr. Sutera, on May 11th. And he's also referring me to Sawgrass Urology for a consult regarding urinary incontinence. We talked about the Axiom PET scan, and Dr. Guercio is unlikely to be revealing, given the excellent biochemical response that I'm experiencing with Orgovyx. Also, I had blood work drawn today for genetic testing here in Syracuse as well. And I think that's all I have.
Okay. Sounds like mostly good news there. Why did you think you needed to have a Axiom scan when you're at 0.06, I think you said?
That was a recommendation from the group a couple of times ago, because I have had 2 PSMA scans that had negative results. And my biochemical recurrence right after surgery was, I was doubling about every 30 days.
Right. So Len, the PSA has come down as a result of the hormone therapies, but we don't know where it's coming from.
Right.
And we suspected that he may not make PSMA. And I'm sorry, Tony, I missed it. Where are we finally on this Axiom scan? Did I missed that? I was writing notes.
Okay, so I pushed several times to get the Axiom scan ordered in my first few weeks of taking Orgovyx, and Dr. Duffy finally submitted it for pre-approval with insurance, and they denied it. So, and then now at this point, so after talking with Dr. Guercio, and his take on it is that we missed the window, that it's not going to show anything. In the meantime, Dr. Duffy took it upon himself to file an appeal with insurance. So that's up in the air at this point.
Okay.
Yeah, but the conclusion with both doctors is that it's not going to show anything at this point.
But it may not. I mean, it may be too late, and because you're responding well to the hormone therapy. So,
yeah.
Right. Okay. Anyone else?
All right.
It's a good follow-up on all those points we discussed before, Tony. Thanks.
Right. Thank you.
Okay, let us go next to Nick.
Sure.
How you doing?
Doing well. Go ahead, tell us your story.
Just an update. Last week I went to see Dr. George at Duke.
Your recommendation.
And basically he looked at my PET scan, my PSA and everything, and basically said, just keep on doing what you're doing.
Okay, so what is your PSA right now?
It's 0.3.
All right, and then that's coming down from
It came
higher
down
levels.
from 9.7.
Okay.
And next week I'm going to get tested again.
Okay, any questions for us or just an update?
Just an update.
Okay,
And Rick, he said, Dr. George said to say hello to you.
Oh, well, thank you. Did you have any discussion with Dr. George about whether to add chemotherapy or not? What was his view on?
He said definitely not.
Okay. All right.
Talking about the medication.
And what medication?
He said, I don't want to call him.
Get that wife of yours on the screen. You know, we can hear her.
She's giving the question.
She's allowed.
I know you asked about the Orgovyx, if I wanted to switch over.
Yes.
And he says, if I switch over to that, I would have to change the Orlita because they don't go together.
Oh, really? We haven't heard that one. That's interesting. Have anyone else heard that you can't do APA with Orgovyx?
Well, it could be that both of them have rash as a side effect, so maybe he was afraid of that.
Yes.
Okay.
That's what I'm on.
And you're on a combination?
Yes, and I have no side effects at all.
Okay. Yeah.
Well,
Well, not everybody's going to have a rash, but
just hot flashes.
Yeah.
with apalutamide, the incidence of rash is about 25%. That's pretty high. I don't know what it is with Orgovyx, but I have heard of people getting rashes from Orgovyx. So that must, well, you can ask them, Nick.
Yeah.
But I suspect that's the reason.
Okay, but
like I said, just tell him you found somebody in the AnCan group who's doing real well on Orgovyx and APA, and the reason we want to get you onto the Orgovyx is because the recovery is so much better.
What way? What way?
In what way is it better?
Your testosterone comes back much quicker.
Okay, I'll bring it up to my oncologist. I'm going to see him next week.
Oh, your local guy?
The local guy.
It's I'm going to keep with Dr. George.
I'll keep in touch with Dr. George either by teleconference or maybe once every 6 months.
Yes.
But anytime we get a PSA, I'm going to definitely message him.
Definitely. He's the guardian angel that you want on your team.
Very, very happy with him. Very happy.
He's a good guy, right?
Oh, very good. You know, if anything happens with my changes, I'm going to him.
Okay. Okay.
All right. Thank you, Nick. Let's go to Scott.
Should I, Scott,
Yeah,
you or me? Or you or Cindy? You don't have to speak.
That's true. I'm not gonna speak, so it's either you or Cindy.
Go ahead, Rick.
So Scott and Cindy reached out to me last week. They were a little concerned about their treatment path. And I was very concerned about their treatment path because they went, I'm going to have to use names here, and I haven't used names before. And two of the gents in this room are familiar with your history. Scott and Cindy were being treated at a local Mass General hospital. And we weren't thrilled with the treatment path. Scott was diagnosed with 4+5 back in the early part of the year, and we moved them over to Dana-Farber. And we suggested a urologist we like very much. I've just lost his name. Remind me of his name. What's your urologist's name?
You're muted.
Yeah, sorry. So the original urologist was local, but do you mean Dr. Keibel or?
Dr. Keibel. Sorry, I was just
All right.
having a mental block. So we referred him to Dr. Keibel and Dr. D'Amico, and they went over to see Dr. Keibel, and Dr. Keibel said, "We want to put you into this trial called GUNS." Now, this happened right around the time that Scott was getting a somatic test with the proprietary testing at MGH that Dana-Farber doesn't use, called Snapshot. And that test came back showing a somatic TP53. Snapshot is a strange trial where if you have certain mutations, the treatment path is laid out. And so the treatment path that was laid out for Scott was 8 weeks of Orgovyx plus apalutamide, followed by 16 weeks of Orgovyx plus abiraterone, followed by a radical prostatectomy. And Scott's 69, and he's in great health. And we said, one other piece of information, and the PSMA scan had identified at least one iliac lymph node in the pelvis. External iliac, so it was high up, so it was quite a good ways away, and he had a positive diagnosis. And we said, with a diagnosis like that, the likelihood that you're going to need extended hormone therapy and radiation is very, very high, because you're already stage 4A. Right. But all of the reports and the meeting notes at Dana-Farber only reflected Scott as being either a 1C or a T1C or a T2A. So this didn't add up. What we've done, and when they met with the radiation oncologist, he told them to go ahead with the surgery, and that would reduce the amount of hormone therapy time. Didn't discuss TP53, didn't discuss T4A, and we were perturbed, because what we feel is happening is that he's getting railroaded into the GUNS trial, and he doesn't belong there. And we see this very often, but we don't see it very often at organizations like Dana-Farber. So what we've done is we've obtained second opinion appointments at Memorial Sloan Kettering, because we want them in a different city. There's no point in saying into MGH. Everybody's too close together here. So we're sending him down to see Dr. Nagar and Dr. Rathkopf, and let's see what they come up with. And before he proceeds along this protocol, moving to abiraterone and then moving to a radical prostatectomy, and then quite likely finding out that he's going to have to do radiation and more hormone therapy anyway. So that's the story. Be happy to, I think I've hit all the big points. Have I hit all the big points, Cindy?
I think so.
Okay. I'll be very grateful to hear. And here's what we're hoping. Here's what I'm hoping. I'm hoping we don't have to make an issue out of any of this, that if Scott does decide to do the radiation, we'll go back to Dr. D'Amico and he'll handle it. The only thing is Dr. D'Amico has not discussed any of the possible radiation strategies with Scott yet. He's just talking about if he were to do radiation, he'd get 28 IMRTs, and I think it's going to be a little more complicated than that. So he really didn't want to get into the radiation at all. So, any thoughts, comments?
And still no treatment of any kind, right? No hormone therapy.
Oh no, he's in the trial right now. He's on Orgovyx and
he did get started. Okay.
And next month they want to switch him to Orgovyx and abiraterone and drop the apalutamide.
Okay, so that's actually going. Okay.
Yeah, so the Dana-Farber genetic testing for the somatic mutations, we haven't gotten back yet. We're supposed to get that next week. And that's when they determine which subgroup you're in the study. The other thing is Scott had a PSA today and it's at 0.2 right now. So the drugs are, you know.
And what was he before he started the drugs?
On March 5th, he was 5.36. On March 12th, he was 4.33. And today he's 0.2.
Okay, so the drugs are doing what they're supposed to be doing. The question here is, how much treatment does he need and what should that treatment be? And we feel that the guns trial is messing up the treatment choices, and the advice that he's getting is being conflicted by the guns trial. The guns trial has had a tough time recruiting. Started in 2021. It's very interesting. There is another arm for TP53, which would give Abi plus or maybe APA plus docetaxel. And Dana-Farber is not doing that arm because they think it's over-treatment. It also is a concern to me because you set up a treatment, you set up a trial, and then one institution says, well, we're not doing that arm because we don't like that treatment. That to me also sounds a little strange. The interesting thing also is that nobody at Dana-Farber has mentioned the TP53, even though that has been back for weeks and must be in his record. So nobody's talked to him about being T4A. Nobody's talked to him about the implications of being TP53.
Right. We didn't know what TP53 meant until you told us. And I had looked it up and I had, you know, with regard to the study and saw that it puts you in a different group, but we were just told, oh, well, they just decide which medicines are best based on the results of that test, but nobody told us anything else about what TP53 means.
So I'm going to pick on Len because Len's the only person, the only moderator who hasn't heard this story before, because I did consult with Dr. John and Dr. Paul. What do you make of this, Len?
Well, I'm not sure that there's a specific protocol for TP53. It's mostly undruggable so far. But I was wondering why, did you say they were moving Scott from apalutamide to abiraterone?
That's the trial protocol.
Oh, okay. So that's the only reason why they were moving him.
Trial protocol, there is no protocol, but there's a trial protocol. If you look up guns, there's a trial protocol. And the trial protocol, if you have a TP53 mutation, which has to be confirmed by Tempus, but it's been identified by Stopwatch, is 8 weeks of apalutamide doublet, 16 weeks of abiraterone doublet, and then surgery.
Sure. Okay, and that's a trial strictly for people who are TP53 positive?
No, no.
Oh, okay.
It's a trial for an open trial, but they test you, and if you have the mutation, that's what they put you on.
Okay. Well, I mean, I agree with Rick that you're not being well served there, it seems, at Dana-Farber and Mass General. So maybe, you know, going down to MSK would be a good idea for second opinion. That's all I have to say.
Yeah. Okay.
All right, we
Anyone?
better get moving here, guys. Good luck, Scott. Jim Aiken.
Thank you.
Thank you.
Yes, real quickly, I've been on Orgovyx for 9 months. 6 weeks ago, they ordered a bone density scan, and I have osteopenia in the neck of both femurs. Dr. Gunzo called for a Zometa infusion, which I had 2.5 weeks ago, and I had a horrible effect from it. I could not walk for 2 days. I couldn't even stand. I had no strength. I really hurt bad. Couldn't sleep. The bottom line is I will not do that again. So my question to you is, I know there are other options. I heard Lynn mention the Prolia. I have a friend that's on that. It's been on it for a long time and had no side effects. That's the shot every 6 months. Is that right, Lynn?
That's right.
And then I understand there's a weekly pill you can take every 7 days. I think it's linodornate. I don't know how to pronounce that. I've got a friend that's been on that 3 years and has had no side effects. So I'm asking other people. I will not go through that Zometa again. That was awful. I'm just barely back to walking normal. It was 2 horrible weeks. So I do not recommend Zometa to anybody.
Yeah, I had a bad reaction from Zometa also. So do you have bone mets, Jim?
Only thing, no, I don't take anything other than just, I take D3 and calcium.
Do you have bone metastasis, Jim?
Oh, no, I don't.
Just a lymph node.
So Prolia sounds like a good discussion to have with your doctor. Get away from the Zometa, talk to him or her about Prolia.
Did you have any side effects from it?
Oh, I never had Prolia, but I had the more potent bone strengthener called Xgeva. It's the same drug, only a higher dose.
Yeah,
I had no problems with Xgeva. I was on that for 4 years.
Yeah, she first recommended Xgeva, but she took me off of that when she realized that it was difficult to get off of it.
Yeah, it can be not difficult, but you don't want to stay on it too long. That's why Prolia, which is a lower dose, might be a better idea for you since you don't have bone mets. I had bone mets, so that's why I was taking it, but you don't.
But, all right, that's all I want to know. I know there are other options. I just want to tell you I had a really hard experience with that, and I just refuse to do that again.
Yep.
So let me comment on that. I did Zometa. It didn't bother me. There are some people who do respond badly to it. Len had Zometa when they finished off his Xgeva, because that's what you're supposed to do at the end of Xgeva. Or denosumab, they do it, and it bothered him. You know, it's hard to really know. You can't anticipate it. I guess that's what I want to say. There are 2 different drugs. One of them is the Zometa type of drug. The other is the Prolia type of drug. So I just agree with Len, talk to Dr. Guanciale about trying to get onto the Prolia type of drug, Xgeva or Prolia.
Okay. All I have.
All right, Jim. The The Gulf Coast AnCan group looks forward to your first appearance with us, I guess, this coming fall.
Has anybody else had adverse reactions in here to either Zometa or Xgeva? No.
I did, Rick. I was coming off Prolia, and they gave me a Zometa shot, and I was fine initially, and then on the third day after the shot, I was really knocked on my behind, and could barely get out of the house. I don't know that I did get out of the house. Could barely get off the couch for a day. But after a day, I was doing okay.
Zometa is infusion. It's not a shot.
Correct.
Right.
Okay, you said shot, but you meant infusion.
Right, yeah, sorry.
Okay. All right, let's get going with Frank Chambra.
Could I ask a quick question?
Oh, sorry,
about
John, I
Gent?
didn't see your hand. Go ahead.
I've been a little bit uneasy about a metastatic guy on only Orgovyx, and so I wanted to know what the latest PSA was.
Is that a question for Jim?
Jim? Yeah, Jim?
Oh, my latest PSA?
Yeah.
I think it was 0.01. I think it's 0.01, I believe. About 2 months ago.
0.01?
Yes.
Okay.
That's the first PSA after taking Orgovyx for 6 months.
Yeah.
Okay, John.
Okay, so I guess you're responding okay without a second drug.
I had no side effects to Orgovyx. I've had no side effects, no hot flashes, even though I'm taking I got the watch, the analog,
Right.
which I use every night. And so I'm very happy with the Orgovyx at this point.
Okay. Thank you, Jim. Frank Chambra, go ahead, Frank.
Okay, the update is I'm pretty sure, I'm not sure if everybody knows, I started the cabazitaxel last Wednesday. My PSA was 24.14 before I started cabazitaxel. They gave me the cabazitaxel and steroids and antihistamine during the cabazitaxel. And then I came home with an onboard patch for, I think it's, what is that for the white blood cells again? It's called?
Neulasta?
Neulasta, yeah, I came home with that. So that's everything that I've done. I've been eating like an animal, for one thing. When I came home from the hospital, I basically was doing my routine, going with the kids, working in the yard and everything. But kind of today, I kind of crashed. My back started hurting me, and I feel there's been really no bad side effects from the cabazitaxel. Just keep moving, getting up, and with that said, I want to thank. I just want to say that, like, for AnCan, I've been coming here for a long time, and I think that the last week, I'm just going to say that how can I say it? I finally I connected so much that I didn't realize how important AnCan was in my life, and that how you guys really, really care. Yeah. And how you reach out to other doctors and you call me back and all of these things, like texting me. And I'm the kind of guy that I don't really want to be like asking nobody for favors. I feel like you guys are busy. You got emails, you got a lot of people. But anyway, so I just want to say I had my come to AnCan moment last week, I'd say. I feel like I'm finally AnCan. So anyway, so for now, we're waiting. My wife's telling me to stop. So for now, I'm waiting for to see if I get approved for a consultation with Dr. Dana Rothkopf out of Memorial Sloan Kettering, which is I'm looking forward to that. I'm hoping in it, but yeah. So I'd say we always have to look forward. We always have to just keep advocating for ourselves. My wife keeps telling me to shut up, but anyway, I'm going to shut up now.
All right. Well, I hope I got to contact Dana tomorrow. I don't know why they haven't gotten back to you. Something got lost in the weeds there. Anyway,
Frank, I had thought that you were going there on May the 5th, which is the day that Scott and Cindy are going. So I thought you could have an AnCan party if you go down there on May the 5th.
Well, I tell you what, I'm from New York, so I could show you a party. But anyway, you don't want to go to that party. But no, so yeah, so it's just we're just waiting on the call back from them interviewing my medical records. Yeah, I've tried calling twice, but just grease the wheel if you want to grease the wheel. I mean, my dad was in here's the kickers, like the personal thing. My dad was in Sloan Kettering in New York City when I lived there, and I visited him there and on his last day, and it was like, so getting in contact with Sloan Kettering kind of broke me down the other day. Like, I didn't tell my wife, but it's very emotional, and so I mean, I'm so thankful. Yeah. Nobody,
so Frank, here Frank, a couple of quick things, Frank. First of all, our experience has been that a lot of men do tolerate the Jevtana well. Now, we don't know, and this is only your first dose. And as we said to you, yes, you didn't get the AMG 509, the xalarutamide, but the Jevtana might do the trick. And when's your next dose of Jevtana scheduled for?
The 13th.
13th. I go tomorrow for a consult.
No, a checkup.
A checkup.
Blood work.
And when are you going to get? So they're going to take your PSA tomorrow.
No, they're going to take the PSA before I get my next dose on May 13th.
Next dose. Okay. So, maybe it'll work. The reason we want you to see Dr. Rathkopf is because she's really on top of the trials.
Well, that's what we want.
Yeah, that's what we want.
That's what you want. Now, have you gotten your sequencing? Are they sequencing your tumor?
No, they're not doing anything.
No.
Well, we feel that you've got to get that tumor sequenced.
Yes, we feel the same way.
And I think that Lisa, you got to get on them. I mean, they can take blood and they can sequence that tumor. I mean,
I asked at the last visit, had a long discussion with Dr. Yang. I read his note. I sent a message to the office after the fact. So I'm hoping that they're going to do it tomorrow. The nurse implied like they would, but I don't know. Dr. Yang doesn't think it's necessary.
Well, you ask Dr. Yang and put it in the portal. Dr. Yang, how are you going to tell us what other trials Frank is suitable for if we don't have a current genomic sequencing? You have to have, make sure we need the genomic sequencing to see what trials Frank may be eligible for.
Okay. I ask a million questions and I don't stop. I'm relentless, but I even waited to see if he put anything in his note. There was nothing from the office visit. So that's why I sent, and the nurse sent back and said that it should be done this week when we go in on tomorrow morning at 7 o'clock in the morning.
Okay,
So
well, don't, my advice is don't ask them for it. Tell them you want that.
I
So you
didn't
can.
ask in the message. I didn't ask. I told him we wanted this test done.
Okay,
I didn't ask
okay.
if they would do it.
And
100%.
just say, and did you also say you want it done in order for us to identify clinical trials?
Yes.
Okay.
And I'll say it again tomorrow. But I
Good.
just,
Okay.
yeah, I'll say it again. Is there anything else we can do for Sloan Kettering besides, we have one lady that, Sherry, that's not calling us back, and is there anything else that we should do? Just
Len?
keep calling her?
Yeah, just keep calling. And if you leave a message, say, this is the third, fourth time I'm
Okay.
calling, please call
Okay.
back. I'll try again tomorrow as well.
Hi, this is Cindy. Scott and I had an easy time. We had a really easy time getting an appointment with Dr. Rathkopf. I have the direct phone number
Yeah,
of.
I think you took Frank's position. When I first called them, they said they had an opening May 5th.
Oh, is
I
that
said,
right?
Frank, you got to get in there quick.
You-
And, but you guys have.
Bless you, Court. That's
Frank,
great.
you can have it.
No, you know what?
No.
They had an appointment May 12th as well. She
Well,
has
when
other-
they haven't even given us an option for an appointment. All they did is
Give
our
them-
medical records. And they said, we talked about AnCan and Rick and Len, and they said, the lady actually said that doesn't even matter. This is the line, this is the person that gets the people, to get a schedule.
Right. Well, let Len see. It does matter because we got Nagar to work on the inside for Scott, and I suspect that Dr. Rathkopf hasn't seen this, and Len will see what he can do tomorrow.
Okay, well, I didn't call today because we've called twice, and I thought I keep waiting. The lady said, actually, she told me she called back that day, which was last Friday, and we haven't heard.
I want to get Danny Langford in because he has something. He wants to share something with you. He started his chemotherapy last week. Go ahead, Danny.
Hey, and shut me down, Rick, if this is inappropriate, but Frank, you said something that sparked my interest, which was the prednisone or the steroids got you eating like an animal, right? And one of the things that I'm really keen on is like, I know I'm a little bit younger, but I gotta maintain my weight. I gotta exercise, right? And these are two things that are extremely, extremely important for me. And if you could see my face right now, this prednisone is making me crazy. But I asked for a GLP-1 to offset that appetite thing that was going to hit me. And I knew that. My wife's a doctor, and she said, hey, let's go for it. So I asked for a GLP-1. And they were a little bit resistant to that, but I got it. And then it's actually, I had my Taxotere infusion on Friday, and it hit me pretty hard Friday, Sunday, and Monday I was coming back around. And my appetite started to flare up. So I took that GLP-1, shut it down instantly, gave me energy, and I've been on the treadmill every day since Saturday, and I had my infusion on Friday. So my point is that I don't know if that's inappropriate. I don't know if it's an edge case to ask for a GLP-1 to offset that hunger. But if we eat too much and we don't exercise, all this is kind of for naught sometimes. So that's just my 2 cents for what it's worth.
I've been swimming, but thank you very much, man. I mean, that's definitely worth looking into, because I am eating like, I've never eaten like this since I'm like 15 years old.
All right, gentlemen, let's get going. Carl in Indiana.
So I got a question for the group. Is anybody familiar with a medication named Nubeqa? I think it's Nubeqa by Bayer.
Nubeqa, yes, that's darolutamide. A lot of us here are on that drug. It's an excellent drug. It doesn't enter your blood, your brain. It gets stopped at the blood-brain barrier, unlike the other similar drugs. So people generally feel less fatigue. It's just as effective. Anything else you need to know?
I have a meeting with my urologist tomorrow, and I came across this, and so I want to bring it up to him. And
This is the kind of discussion you have with an oncologist. Why would you be seeing a urologist? Do you have, what is your?
It's my regular, it's just my regular appointment with him.
But why are you still seeing him, Carl? That's the question. You don't need a urologist at this point in time. You need a, we've mentioned this before, you need a medical oncologist. It's beyond the knowledge of these guys. We feel.
I actually have both.
Okay, but you don't need to keep seeing the urologist unless you want to send his grandkids to college.
Well, that may be it, Rick. I don't know. but I was going to bring it up to him because I do have an appointment to see him tomorrow.
Yeah, I mean, I'm not sure. The answer is yes. We like that drug very much. Okay. It's a really solid drug. I should let Len talk about it, but we also feel that your quarterback right now, you only need one quarterback. Unless you've got urinary problems, you don't need to be seeing your you don't need to be seeing your urologist. Remind me, Carl. You're the singer, Carl, right?
Yeah, that's all right.
Yes. Remind me of your last name, or put it in the chat window because I can't find your notes.
I'll just tell you, it's very simple. L-A-I-B, Laib.
L-A-I-D, okay.
No, B, as in boy.
Oh, L-A-I-B, right, okay. So Len, do you want to say anything else?
Well, I think I told you everything you need to know about Nubeqa. It's a great drug. Many guys feel that, well, in the studies, there was very little difference between, looking at side effects, very little difference between Nubeqa and placebo. But it is effective. It's not a placebo. It's very effective. And I'm not sure why you want to talk to anyone about it. Did someone tell you need to be on another hormonal therapy?
I had a blood panel done on Monday.
Yeah.
When the test results came back, attached at the bottom was an advertisement for this medication.
Yeah.
And I'd never heard of it before. Maybe you guys talk about it, but you may not call it that.
Yeah, we call it darolutamide more often.
Yeah. And so I just wanted to know.
Okay. Yep. Okay.
What medications are you on right now? I have a record that you're doing Orgovyx and enzalutamide. Is that correct?
Is Xtandi the?
Yeah.
Yes.
Yeah.
Yep. And it seems to be going well. I mean, when we started this out, I had a PSA of 29.3, and then it went down to 2.4, I think it was, and then 0.06, and Monday it was at 0.04. I mean, it's definitely, trending downward in the right direction.
So our feeling is, I mean, if you're tolerating the enzalutamide okay, maybe it's worth letting it alone. Do you have any brain fog?
Well, if you ask my wife, no, but my cognitive ability is not the same as it was when I was 40, Rick.
Mine neither.
I can still read my music. I can, still count musically, and
look,
I'm doing.
The bottom line is this: we feel that darolutamide is a much better drug than enzalutamide.
Okay.
If you're not having any issues, then why mess? If you were having issues, we'd say think about switching.
Okay.
But Len, what would you say, or Dr. John, what would you say? Should he discuss it? Should he not discuss it?
Without having side effects, why change? I agree.
Yeah,
And,
I
you know,
agree.
we're not comparing ourselves to what our brains were like when we were 40. We're comparing ourselves to what our brains were like before we started our treatment. If your brain is much more sluggish than you were only before you started the Orgovyx, that might be a reason to switch. But
Yeah,
if you're
I
just as
can't say
sharp
that.
musically as you were before you started the Orgovyx, I agree with Rick. Why mess around with something that's working?
All right. I just thought, you know, I would ask and get more information, but since I was meeting with you guys tonight, I said, hey, I'll ask these guys because they know, you know, almost everything. So,
Okay, so now you know.
there you go.
Now you
so
know
much.
our opinion.
Yeah.
Rick, I have my son visiting. I'm going to turn it over to you. The next one up is Jeffrey G. And then after that, we have John Maxwell and Anthony, and that's it.
Okay. So, and then Anthony. Okay. Which son's visiting?
Dan. He was in California.
Yeah. Tell Dan I said hello.
I said
Dan's in California?
No, he was. He was out there for a wedding, but he's back now.
He's back. Okay. All right. I will.
Alrighty.
All right. Okay.
Ciao,
All
ciao.
right, guys. So we'll probably go another 20 minutes to half an hour. And Dan M, after Anthony, I'd be happy to do an intake, or we can do an intake next week. It's your call. If we do it next week, you will be the first one up of the newbies. You'll be a carryover. And so, all right, Jeff G. So I asked Jeff G to take time because right at the end of the meeting last week, and I'm just making sure, is he still with us? Are you still with us, Jeff?
Yep.
Yes, there you are. I see you. Yes. Right at the end of the meeting last week, Jeff slipped in some information that he just found out he was BRCA positive. I think David Frank is probably no longer in the meeting, but you know, the BRCA information is really, really important.
David.
Are you still here, David?
Listening, yes. Mm-hmm.
Oh, you're listening. Okay, great. You're listening. All right, great. So, because you'll get something out of this as well. And what I did was suggest to Jeff that he get himself a proper genitourinary medical oncologist, like Dr. Audio, by the way, David, who is a very solid GU medical oncologist. But Jeff didn't have one. He had a local guy. And I suggested he go up to City of Hope in Phoenix and meet with Dr. Alan Bryce, who was the chief of GU oncology at Mayo until City of Hope recruited him. And he's now at City of Hope. And he's a very, very solid doctor. And that's where we left it. And so I wanted to hear from Mr. G there whether, in fact, he's reached out to Dr. Bryce. Dr. Bryce said he'd be happy to talk to him because I wrote to him.
Right. Thanks for that, Rick. I really didn't realize the significance of the BRCA2 until like early in last week's meeting, and that's why I decided to toss it into the chat. And I was like, I dropped a little depth charge.
Yes.
So thank you for the referral. I have an appointment. I'm going up to Phoenix on Thursday. I have a pre-interview with a nurse tomorrow where we'll go over our meds and I guess some of my history. And, BRCA2 is serious business. So I knew, about the family history, the Ashkenazi Jewish part on my father's side, and him having cancer and his mother dying of an early age of cancer. And also my mother with the three big ones, ovarian, breast, and pancreatic cancer. She died of pancreatic cancer at a late age after a lot of treatment. And her mother also dying of, I'm just going to say breast cancer, but I really don't know. So I knew about all the history, but I didn't have the science. So I do have an appointment. Go ahead.
That's great. And what I really would love for you to focus on, and David, Frank, if you haven't focused on this yet, also with Dr. Audio, and talk to Daryl, because he's pretty much on top of it. All the other cancers that you got to get yourself tested for. I mean, some of it, hold on a second, David, and I'll come to you. Some of it is easy. For example, you can do your own breast examination. And I think I also asked Bill Harris to reach out to you, because he's a real advocate for BRCA germline. He's had 3 cancers and he's a real advocate for BRCA germline. You've got to watch out for melanoma. You've got to watch out for pancreas cancer. We had a couple of guys on our on our group, and you've seen it now. You've participated in that group talking about their pancreas tests last week. There's a bunch of cancers that should be right up there. And if you can get yourself onto a schedule to do the testing, that's as important as managing your prostate cancer. David Frank, what's Karen Audio said to you about managing the other cancers?
Initially, I remember when we were first talking about it, she said that it's rare to get more than one of the cancers that you can possibly get with the BRCA2 mutation, but she does recommend testing. At the time, I think she said, let's wait until you're more settled into your prostate cancer treatment. But I believe it's out there in the offing, and we're going to get into that.
Yeah, I mean, the other tests are not too bad, other than the pancreas. The pancreas one can be a little invasive. I think the others are not, but I think you really need to make an appointment with her and talk to her explicitly about what you need to be doing. I mean, and I would, she's a good oncologist, but I just have to tell you, it's not so rare in our experience to find people having multiple cancers with a BRCA mutation. Is Jeff Markey? You're a BRCA one. Yes. You're a BRCA 1 or BRCA 2? I can't. BRCA 2. I mean, in your experience, talking to other BRCA people, how often do you hear them dealing with more than one cancer?
I really have not. I've only heard women and men who only had one so far.
Okay.
I mean, my grandfather had pancreatic, so I was tested a couple of weeks ago. I had an MRI for it, but it's not likely at 78 that I'm going to get it, since I've had.
We've David, we've seen it too often. I mean, like you just heard with Jeffrey's mother, and we see it. We see it. And you're at a lot higher risk, and it's not something to sweep under the carpet.
Oh no, it's something that I will definitely be. Something that I'm definitely going to be screening for.
Okay.
Absolutely no question about that.
Okay.
I have a short one. Rick.
Yes.
So you know that I went on a doublet holiday April 2nd after 6 months on Eligard and Rebecca. There were some changes. But one of the changes was a skin disturbance. You know, I'm not seeing a skin doctor, but they're right away when I started on the therapy, these skin abrasions, I don't know what to call them, the lesions,
rash,
they just dried up. And I thought that was a result of the lack of testosterone. But since the holiday started, there's been some action. And, you know, it concerned me enough to send a note to my doctor here locally, the medical oncologist. And he's got me coming in tomorrow for a quick PSA and a CBC. So, you know, I'm on alert about, you know, a sudden rise in PSA after this holiday started. Anyway, I just wanted to get current on that.
Well, the one thing I would say is, Dr. Bryce, I mean, you've got to take the advice of Dr. Bryce. Notwithstanding your local guy, Dr. Bryce is really the go-to, and you'll see him next week, and he should be going forward where you want, who you park your care with. And whatever this guy says, you've got to park. Now, the fact that you had this rash has come back since you stopped the hormone therapy, that's well above my pay grade. I mean, I know a few guys who have gotten rashes when they started the hormone therapy, and especially when they've started darolutamide. I'm looking at one right now. He doesn't know who it is, but I know who it is. But we've had plenty of guys who have gotten rashes when they've started, but not too many who have gotten rashes when they've stopped. Anybody got a rash when you've stopped the hormone therapy? Anyone else here? So I don't know.
You know, there's been a surge in testosterone since then. Maybe it's provoking an acneiform type of rash.
Yep.
You know, if I had a skin doctor, she'd tell me it was a melanoma, but
no.
I'm just not being treated for that. Anyway, we'll leave it at that. Thanks, Rick, for the time.
Yeah, and you know, definitely bring that up with Dr. Bryce.
Okay.
And we're anxious to hear how you do with Dr. Bryce, and you'll tell us, and give him my best and thank him for seeing you quickly.
Thank you. Thank you, Rick.
Okay. Moving on, and next is, wait a minute, he told me Jeff G, John Maxwell, Anthony, and somebody else. Who was the other person who still wanted time? John Maxwell, I know. Anthony. I thought he
had 3.
Oh, you thought he had 3? Oh, I might have written John and then Maxwell underneath. So John Maxwell.
Hi, guys.
Give us a poem. No, we don't have time.
No, no poems. So first of all, thank you. It's great to be here. I appreciate seeing all of you. I'm going to give you the bottom line, but then how I got here is important. At the end of March, I stopped ADT. Okay, so I'm not on anything right now. Let me quickly bring you up to how I got there. Diagnosed in December 2024 with Gleason 8. I had 3 cores, a PSA of 12.5, T1C. I had a PET scan, no metastatic spread. So it's all in the prostate. Talked to 9 doctors in Chicago, found a couple I liked, and I said, I want you to hit me with everything you've got. I want maximum therapy. So they put me on Orgovyx in February. They put me on abiraterone in April. I got brachytherapy also in April. And I got 25 fractions of EBRT in May. And so at the end of May, 112 days after my first Orgovyx tablet, I was undetectable for PSA and testosterone. I stayed absolutely undetectable on PSA and testosterone for 10 months. And so after being on ADT for 13 months, absolutely undetectable, I read the MARCAP study, which some of you may know about. And the MARCAP study said, well, you really shouldn't be on ADT for exactly my kind of cancer, non-metastatic, for longer than 12 months. And so I compared myself to the population. I had a 4+4 and I was in the high risk. And it said with high risk prostate cancer, staying on from 12 to 18 months would reduce your risk of metastatic disease by 2%. And so, but I got brachytherapy, which nobody else in that sample did. I had abiraterone, which nobody else in that sample did. And I was undetectable for 10 months on both. So I went and I sat down with my GU oncologist. We had a good, candid conversation. And I said, I think I'm done. And he said, okay, stop taking Orgovyx and I'll see you in 3 months. Questions, reactions?
Well, wait a minute. David Muslin, you know who his GU Medonc is?
What a long name, is it?
It's a lot of a long name. You
Smolowitz,
might know him.
Dr. Smolowitz, who's excellent, by the way. He's excellent.
So what's your response? What's your response, Mr. Muslin?
I happen to love Russell. I call him Dr. Russell. I call him Russell. He's pragmatic, and obviously you're collaborating with him like I collaborate with him, and listen to what he says. He's got your back. I don't know what everybody else here says, but I believe in Russell Schmuelitz.
And now this is the epitome of advocating for yourself. We tell everybody, be your own best advocate. And we want you, we may not agree with you. You may want to do something that we don't necessarily think is the best thing, but if you think it's the best thing, you take it to your doc, you argue it with your doc, and come to agreement with your doc. John's done it. David's done it. A bunch of you in here, but Jim Marshall has done it. And it's what it's about. We may not be able to change the course of your disease. What we can do is at least try to let you know what is best, we think is best, but more important, that you can make yourself heard in front of your doctor.
Yeah, I would say it was a very amicable discussion, two-way. But really what it came down for me is that study, which I think is highly credible, with 30 docs on it, and JAMA published it. And JAMA's not publishing that without looking at the data. But it said my improvement in my outcomes is only 2% with another 6 months of ADT. For me, hold on, I got to be clear, for me, right?
Yeah.
And I said, why would I do that?
How did Dr. Russell respond when you said that to him, John? I may have missed that.
So he said, well, you know, there's going to be some clusters of cells out there. Some of them are dying and some of them are just sleeping. And, you know, we just don't know what that looks like yet. And he's being very pragmatic, of course, right? And he said, well, the study wasn't exactly the same as the treatment you got. And I said, treatment I got was a lot more aggressive. And after we went back and forth for a while, he said, stop taking Orgovyx, stop taking abiraterone, and I'll see you in 3 months.
And the beauty of Russell, and I won't say anymore, is he tells you to come back in 3 months because he's going to watch you very closely.
No,
if you need to make a shift, you'll make a shift. He's big on talking to me every 3 months. He doesn't care what's going on. I'm checking with him every 3 months.
Yeah, I think he's fantastic. So it was a really big decision. And for a week, first of all, within a week after I stopped everything, I felt better, and I felt like a fog lifted. It was palpable, right?
Wow.
And I didn't know I was in it until it lifted.
Wow. Wow.
And so I feel great. Exercising, I worked out 6 days in a row right afterwards, and my body said, no, we're not going to do that. And so I slowed down. But you know what? I'm on the journey. Am I cured? You know what? I'm never going to say that. But I felt like it was the right decision, and I feel good about it. So
wow. Well, and you were on Orgovyx, correct?
I was on Orgovyx and abiraterone.
Right. So have you had any blood tests since you came off at the end of March?
No, I had one right before I came off.
Okay.
All my blood work looked terrific.
Okay, so we'll see what happens, and it'll be real interesting to see how quickly your testosterone's coming back, because we really feel that it comes back a lot quicker off of Orgovyx, and you were only on for 12 months. So we'll watch that. That's really.
I was on for 13 months. 13 months.
13 months. Now, everybody who's still here and everybody who's still listening on the podcast, check the chat window, because I've also added the Solo Arts Heal interview that Hannah did with John, which was a wonderful interview and worth watching. You can click on it right now and you can watch it later. But yes, that was a great interview.
Bless your heart, Rick. I so appreciate you giving me that opportunity, because I'm primarily a poet at heart.
There you go. I told you if we'd have more time, we would have had you read us. We would have had you read us a poem.
Okay, well, I'll bring one back next time sometime.
Yeah, one back next time. David, Jim Marshall, I think you said what you wanted to say, or did you have something else?
No. Yes, I'm curious. How did you stop the prednisone?
We talked about that. He said, after you stop the abiraterone, I want you to stay on prednisone for 5 more days.
Okay. I was just curious. I wanted to point it out for folks who think you can just stop it and quit it. Okay, great. Fantastic.
Good point. And how long have you been on weaning off the prednisone, John?
I stopped Orgovyx and abiraterone on a Friday, and I had 5 more days of prednisone, and then I stopped. He told me 5 days.
Oh, wow. And you're okay? Because that's a fairly short period of time for prednisone when you've been on it for 12 months. But if it didn't have adverse effect, we're good.
No, I didn't have adverse effects, but you know what? I'm still in ADT, right?
Yep.
Well, we don't know. We'll find out.
We'll find out, right?
Right. David, go ahead.
And just one last thing, John. Keep coming back and share your journey with us, because when you're on a different journey than everybody else, it really helps us. So it helps all the men in our group. So please come back and share with us how you're doing from time to time.
David, thank you very much. And I will, because I couldn't have done this journey without all of you. 100%. So I will be back. Thank you. And I'm not off the journey. I'm still in it. It's just a different version of the journey, right?
Love it. All right. finally, we get to thank you for your patience, Anthony. Again, I've got to find your notes because I do remember talking to you, but I need your notes in front of me. So you may need to have to give me a jog with your last name. I think it begins with a T. Am I right? Yes. There you go. Okay. So tell us.
What is it, Rick? I'm looking up to. What was the last name, Anthony?
Can we say it out loud, Anthony? Is that okay?
T is enough. I'll find it.
Okay. I'll send it to Dr. John. So tell us what's going on.
Cannot hear you, Anthony.
Well, the question I have, Anthony, was were you in this group or were you in the low intermediate group last time? That's where I'm having some issues.
Still cannot hear you, Anthony.
Your PC audio is the problem.
Yes.
Yep.
You got it first time last time around.
Okay, I found the problem.
Oh, there we are.
You found the problem.
Yes.
All right.
Which group were you in last time? Because I don't seem to have any notes.
First came to AnCan, I was in the low group, but you suggested that I come and join the high group. So I did start out in the low first, and then I came over to the high.
Oh, and is this your first meeting in this group?
Yes.
Okay. Well, I'm sorry to do this to you, but we need to do an intake for you, like we did with the 3 guys at the beginning.
Okay.
And
we can do that next week.
Yes. And next week is going to be a little bit crazy because I've already got 2 new guys who are you and Dan M. So it looks like a good chance that there'll be a carryover to your week, Dr. John.
Yeah.
Busy. Excuse me, Anthony, are you a veteran?
No.
Oh, okay. I got that out of the way. Thank you very much.
I only had an update anyway, so it can wait until next week or the following week. It was only an update, so.
Well, we need to just get you in because I don't have notes. Dr. John probably does have notes on you.
No, I've just been through my cards. I don't have anything.
Okay,
and it's not in the LGL either.
Okay,
so we got to start from scratch.
Yeah, we got to start from scratch.
Next week.
Okay, so listen, we better stay on a little longer because we don't want to wake up Jeff Markey. Look, he's here. Okay. Anybody else have anything just before we close out?
No.
We're in good shape. Frank's in good shape. I would love to see Scott and Frank be in there on the same day. I would love to see that happen, but I don't know if it's going to happen. You guys need to be in touch with each other. I hope you exchanged emails. If not, write me and I'll put you in touch with the.
Yeah, thank you very much. I appreciate you guys. Thank you.
Okay. All right. I'm gonna close out the meeting. Good night, everybody. Good night.